I'm going to talk about PrEP. I've changed one of the words, but English is a bit varied, so we can play around with it. Who, what, and how. I've been following the PrEP scene for a long time, and my real introduction to it was when I was asked to chair the proud DSMB, and we eventually stopped the study because of the results. So it was quite an onerous task, actually, but I was glad that we did it. So let's start with why PrEP. Well, here's why I believe, and I think UNAIDS are now moving around that, why 1990 is not going to end the AIDS epidemic. It certainly won't stop HIV. Here's Botswana in Africa, almost there at 90, but their community HIV incidence is 3.1% still. Partly because they only describe their own people. They don't discuss, because they don't treat migrants. So there's transmission. I mean, it's not like people live in a silo. There's transmission between people who aren't treated and people who are treated, and this will continue to carry on, and they will not, even though they might reach 90 in their own population, they won't eradicate AIDS. They're now trying to say, oh yeah, AIDS is a clinical disease we might eradicate, but not HIV. But, this is just semantics. What we have to do is stop HIV. So, and you can see this was all published in The Lancet. So what can you do? Well, if I can get there we go. If we're at the status quo, the HIV epidemic won't be under control, even if we give 100% antiretrovirals to everybody, right, at CD4 200 like it was before, it won't. And even at any CD4, it still won't make it, as you can see from the 1990 data that's around the planet. If you add circumcision, you will make an impact. If you do this is the early art, everybody getting antiretrovirals, plus changing the structure of healthcare, you can almost do it. But actually, you have to add in PrEP and behavioral work to be able to control the epidemic. And it is achievable if you start to do this. So who needs PrEP? Well, let's have a look, because what happens is that we're all a little bit involved in our own countries or in our own regions, but actually globally, if you look at the top 10 countries of people living with HIV, which you can see here on this side of the slide, you can see that 61% of all the HIVs in these 10 countries. Now, if you take Europe's about the same size in terms of the HIV epidemic as the USA. So if you took Europe as a chunk, it would sort of bump Zambia off this 10th place. So this is where we have to, if we want a global control of HIV and AIDS, these are areas where we have to concentrate on PrEP. And if you look at the global distribution of who's getting HIV, you can see here men and women 25 years old and more occupying most of it, and in sub-Saharan Africa the same. And the reason why these two charts are very similar is most of the epidemic is actually driven by these people in sub-Saharan Africa. So if you go to Africa, who's infecting who? And it's a really interesting cycle of what's happening, which could be broken by doing preventive measures, including PrEP. So you've got these men, mean age 27, and what they do, they have sex with the people who are similar age of them, the women similar age with them, and they have sex with young girls, youths mainly, if you look at this, 16 to 23. Okay, then these women who get infected by these men grow up, and the ones that aren't infected, or are infected either, the ones that aren't infected then get infected when they're a bit older and have sex with men of their own age, and the ones that are infected will infect men of their own age. And this thing keeps going round and round and round. It has to be stopped. And okay, you could try and treat everyone with antivirals, but the other thing is these young women you could give PrEP to prevent them from being infected. So the highest burden in sub-Saharan Africa is in young women, and this is from all of the data that's ever been seen, that actually it's young women in sub-Saharan Africa. If you're going to give PrEP to anybody, it's those people that you should really concentrate on. Also, the women are going to get pregnant, and if you look here, unintended pregnancies globally and in Africa, it's huge. So if you don't protect these women and they get infected with HIV, they have HIV-infected babies unless they get diagnosed and treated. So if you actually give PrEP to young women, then you're actually stopping them getting HIV, and you're having, as they call it, an AIDS-free generation just by giving PrEP to these young girls. And if you are pregnant, and HIV negative, but you're still at risk, obviously you could still give PrEP. Okay, and there are lots of HIV serodiscordant couples where the man's positive, the woman's negative, the woman gets pregnant. What are you going to do? Keep the risk going on. You have to treat the man, and I'll show you later that while his viral load's going down, you should definitely give PrEP to the woman. So let's move away from heterosexuals now and look at Thailand. Now, Thailand's very interesting. What's happening here is that in Thailand, the epidemic is now becoming male-male sex dominated. It used to have some injection drug use, and it used to be male-female, but if you look here, heterosexual, if you look here, it's becoming now more of an MSM epidemic. And if you look elsewhere in France, you know, look, France, and I could show the same in the UK, very well-resourced health services, lots of antivirals available, so why isn't it that MSM rates are coming down? Why not? Well, because there's lots of reasons, but one of them is that they're not getting PrEP. The people who are actually infecting others are not being found. And you've really got to say that how can 90-90-90, you know, which is almost achieved in the UK, we still have this same problem of MSM epidemics. And everything else is just flattening out. We've got to do more than just giving people treatment. And if you look in Australia here, the majority of infections are in MSM. And again, look, and this is, New South Wales in Australia is fantastically well organised, right? The doctors have great access. They test the patients, they do all sorts of things, but you can see it's still flattening out when they're not getting control of the MSM epidemic there. The other thing that you have to remember and realise is about transgender men, and transgender MSMs are at risk from non-transgender male partners, all right? And they have high, you can see here, the high risk in the blue bars of developing HIV. And even more so, transgender women. And transgender women, when you look at this, they have huge rates of HIV burden. So again, although it may be something that in your practice you don't think about too much because they're probably a small percentage of who you see, and and obviously these are ones that are HIV negative. The ones you guys are seeing are HIV positive, but your colleagues might be seeing them, or you might be seeing them in the sexually transmitted infection clinic. These people should be targeted for PrEP, and understand why. And in Africa, it's very interesting. There's a large number of transgenders, which people don't realise until you actually go and do the research. It's interesting what you think is or is not in your in other parts of the globe. So WHO have put out guidelines to say that it should be given to people at substantial risk, it's here, of HIV infection. I've tried to show you some of the people that we should really think about giving it to. And it's quite incredible. If you look at all of this, so in the big circles, it says like regulatory approvals for PrEP. This is since last year, right? So this is in the last 9 months. 8 of those have occurred. National strategies, 5. 2 in the development since last year. 30 implementation. So PrEP is going global, and so we need to know about it. We need to know about it in big detail, because in your clinic you have to start thinking, how are we going to roll this out? Whose responsibility, and what are we going to do about it? So a little bit about the what PrEP. And really, if you look, most PrEP since 2011, and here are all the studies on FTC tenofovir, you can see here there's lots and lots of projects. 32 projects, 16 countries. This is just the research, 8,500 participants, and you can see the seroconversion rate is 67 out of all of these 8,478, and almost all of the seroconversions had very low levels of the drug. In other words, they weren't taking it. So PrEP works. And here's the PROUD study, 86% protection rate, and the number, you need to give PrEP to 13 people to prevent 1 infection. That's hugely useful in terms of a figure to know in terms of trying to convince people how good PrEP is. And when you look at Ipagay, where they actually took it on demand more or less, they took 2 pills, then 1 pill, and then 2 pills at the end. You can see here that again, 86% protection rate. And even in this OLE, right, that's not me misspelling Olay, this is the open label extension, right? So even in there, the incidence was very low. So PrEP works even in the long term. And this is all in gay men. But not everybody wants to take PrEP. Here are disadvantaged black MSMs. And if you go to parts of the States, there's an epidemic of HIV in black MSMs. 79% decided they would take PrEP, and 11% didn't. In those that didn't take PrEP, you can see how many of them got infected over 12 months, whereas the ones that took PrEP, okay, the rates were much lower. And again, the seroconverters were really all around discontinuing it. So it's another message to think about. It's all right to prescribe it. What have you got to do in the long term to engage everybody in PrEP? And it is effective if you take it. I mean, there was that famous quote by the American Surgeon General, the pills only work if you take them. And here's the same. And lots of these studies were disappointing at the beginning, but you can see that is because they weren't actually taking their drugs. As soon as you start taking the pills, it's fine. And we saw that with the vaginal ring. Those women that took the vaginal ring had much better success rates than those people that didn't. And what do we know? The poor results amongst young women, I've already stressed that about young women in Africa. The poor results from these studies here are almost all related to not taking therapy. And you can see early lessons, and this is something we have to address. We can't just say, oh, hello, you're at risk of HIV, take this pill. All right, this is some of the things that young women have said about the stigma, about they don't want all the sort of packaging with PrEP written all over it, or HIV. These are HIV drugs. They don't want to have to go to HIV services to access it. They want support from their communities that it's a good thing to do. Obviously, they need help in not forgetting. They're worried about side effects. And look, all of this stuff we had with the HIV epidemic in the beginning when antiretrovirals came out. It's no different in a way to what we've got to address with people who are HIV negative who want to protect themselves. But the good news about women especially was this partners demonstration project that's just been published. So this is what they did. You can see in the top here, here's your HIV partner starting on antiretroviral therapy. But as you know from the HTPN 052, some people get infected while the antiretrovirals are working in their partners. So as the viral load's going down in their partner, the HIV negative person could still get infected. So to stop that, what you do is you test them, one's positive, one's negative. You give the negative for 6 months here, PrEP, while you've got time for the antivirals to work. Now, in those people who said, I don't want to start the antiretrovirals, I'm HIV positive, I don't want to start them today, I'll start them in a few months, you say to their partner, hang on, he's not going to start for a few months, or she's not going to start, why don't you start PrEP today? And that's what the second bit showed. That's the second bit of the diagram. So this was really protecting the HIV negative person until the HIV positive person was undetectable. And you can see here there are 1,013 couples, and this is some of the demographics. But if you look, there are only 4 seroconversions, and I put in bold here, no tenofovir detected means they didn't take it. Declined PrEP means they didn't take it. No tenofovir detected. I mean, it's boring in the end. Basically, if you take it, it works. And and this is a very good strategy for lots of places where people go to start antiretrovirals. What is your partner's negative? Please, we're going to give your partner this until you're undetectable. This way, even if you cut a few % of all the transmissions down that would, that occur out of all the global transmissions, you're making some impact. And you're making a huge impact on that family, especially if the uninfected person's a woman, because she'll stay negative and be able to have negative babies without a problem, okay? If she becomes positive, she needs to go on therapy, and then you've got a concern about a baby when she's pregnant. The other interesting thing about PrEP that we mustn't lose, especially with women, is that there can be differing concentrations of PrEP in various tissues, and the Maraviroc story is one of them, and you have to be a little bit careful when we're looking at men and women for PrEP to make sure that we've got the biology and the PK right. So what's the future of PrEP? Well, there's all sorts of things going on. Novel strategies to communicate with people to make sure that they find it. I'll go through the list of the new drugs. The intravaginal ring. As the Australian lady said, who asked the question, The intravaginal ring will work if you have vaginal sex, but if you have anal sex, there's nothing there to prevent it. So, you know, it's interesting how local things work locally. So we've got oral PrEP. We've got, and there's TAF coming as well. Will that be good for PrEP? Because then the problems with side effects, perhaps from tenofovir, will be down. There's lots of different things that people want to use in injectables, and cabotegravir presented at IES. I'm not going through all of these because otherwise I'm here till the end of the day. And one of the interesting drugs is the Merck drug, which seems to be able to have a terminal half-life of probably up to a year. So they're working on an implant. Imagine that, you could put an implant in for several months. So that might be useful. So there's a lot of things going in terms of creativity in the PrEP pipeline. So who's actually taking it? Well, the US say that this is how many people should take it, right? At least 25% of sexually active men should be on PrEP. Just look at the numbers here. It's almost 500,000 people should be on it. People who inject drugs, heterosexual adults, a small percent, but they're a big part of the population. So that's it's 1 million people. When you look at this, 1 million people in the USA should be on PrEP if you think that they're at high risk of developing HIV. So you can see what's happened since PrEP's been available in the States. They've had a large increase in numbers, but when you look, the total number, 150,000, you know, and this is unique people have started, 80,000 people have started. It's quite interesting what will happen in the next few years. But if you look at this is the general population of the US, and I want you to focus on black African Americans, make up 10%, right? Then when you look here of the population distribution by, these are the total PrEP utilization, 10%. And it's 12% of the population, but if you look at the people who have got HIV at the moment, 44% have got it. So we really need to try and ramp up what's happening and get it into the right populations, because there is an issue here, especially in the States. And if you look at men and women, they were pretty much the same early on in 2012, and now the message has got through to gay men. I'm not sure if we've got the message through in the States to women. And as I've said, there's enough vulnerable women there. And the problem is physicians maybe are only thinking PrEP equals gay men and doesn't mean vulnerable women. In France, you can see the implementation's gone right up since it's become available, and more physicians are now prescribing it. When you look in Thailand, they have a program too. Number of PrEPs going up, right? It all looks exponential. I hope it is until we get saturation of PrEP. That's happening, and they've expanded it to 3,000 and their MSM over the last 3 years. Now, what the few problems PrEP bring, I'm not going to do all the metabolic things about tenofovir. I'm just going to specifically about PrEP, what people worry about, and this is the real life rather than clinical trials. Adherence 92%, no seroconversions in this guy's cohort. About 22.5% discontinue it. So you really need to find out why these people have discontinued. It's really important why. And it's increased associated with being female and drug and alcohol use. Well, we know drug and alcohol use impact your adherence, but also being female, some of this needs to be worked out more. Only a few because of renal problems. Okay, and he did find increasing diagnoses of rectal chlamydia and urethral gonorrhea in this cohort. Whereas if you look at the IPAGAY, basically the rates of, in the double-blinded part and the open label of last receptive anal intercourse was going up a little bit, all right? And remember, these were very, very high-risk people. But it wasn't sort of everybody. I mean, they started off at 77%. It's hard to know how much further you could go. Or maybe I'll rephrase it. Okay, so overall, from the trials, there's been no real increase in condomless sex. A modest increase. It's only been a modest increase in the open label studies. I've just shown you that. And it may be that incident STIs are an indicator of condomless sex, and I agree with that is probably true. And PrEP probably is now reaching a population of high risk. And especially if you use syphilis. If someone's had syphilis and is HIV negative, I think they should be talked, if they're MSM, they should be saying, hey, you should be going on PrEP. Now, what about resistance? I see Jonathan's in the audience, so he's always interested in this. The overall risk of FTC or tenofovir resistance in this is very low indeed. So I don't think we should be getting concerned about resistance in the PrEP trials. And there's been one case of a guy who had a transmitted multi-drug resistant organism, which then virus, which then of course he was on PrEP, it didn't work. His drug levels were absolutely fine. So, but these are rare. You know, these transmissions they happen anyway. So the thing is, if you look at the public health view, of very few seroconversions compared with the amount of PrEP you could give, and saving for every 13 people, you save one transmission. You can see that these things may be blown up into out of proportion. And always highlighted and published, but actually the major benefit is still there. So for the cost of PrEP, well, you can see what it costs here in France, right? It's a lot of dollars. It's a lot of dollars. If you look at Thailand, it's $18 to $22 compared with $4,000, right? So it's very much smaller because of the generic use of PrEP. In Brazil, they've done cost effectiveness, and basically the cost effectiveness is they cost them $460. It's less than 4% of an individual's GDP, that's GDP per capita. So it's very highly cost effective to prevent HIV. Imagine how much that costs if they got infected, right? So compared with that, it's hugely cost effective if you can get the Truvada cheaply. And now implementation, you guys, me guys, right? You guys in the USA, a majority of HIV specialists where you can prescribe say would do it, but only 1 in 3 infectious disease doctors who look after HIV have ever prescribed it. All right, and here are counselling, considered part of the clinical role, have done it in the practice, right? Visits and prescribing PrEP, only a third have probably done it. So we have to be more proactive when we see people who are HIV negative. Also, the patients, when you talk to them, and the doctors, when you look at the patients, a lot of them are uncomfortable talking to their primary care physician. That's interesting, isn't it? Because we don't get that in our STD clinics, but in primary care, if you go to your primary care physician, maybe you would be. And even when comfortable talking about sex with your primary care physician, you don't tend to raise the, shall I go on PrEP? Okay, this is in the States where you can do it. And it's interesting, most of the MSMs think their doctor won't give it to them. Wow, so these are real barriers for us to think about in our practices. We also need political support. The governments have got to support it. You can see France has supported PrEP. You can see Australia they haven't given out PrEP because they're still working on the cost effectiveness, but they've supported this study and giving in New South Wales and giving drug for that. And in Kenya have actually grasped what WHO have said and are also doing this. And look what they're doing, oral PrEP recommended for these key populations. So Kenya are doing, if all these countries can do it, so can our countries. But we need to get on the side of the politicians. You also need community engagement, and if you can't get that, you're lost. So you really need to mobilize that, and Thailand have done that fantastically, and so have the French. And the messaging is often being poor about PrEP. It's got to be positive. It's not take this and you won't get that terrible disease HIV, right? You can't build on fear and stigma. You've got to get the right messaging, and obviously every country's got different messaging, and social marketing is really important. And of course, all the stuff we have, Twitter, Facebook, all that stuff that I sort of dabble in but not very good at, can do it really well, okay? And if you look here about young people, young MSMs, what do they think? When you look down there, they're worried about pill size, the taste. Who's ever thought about, oh my God, that pill tastes terrible, right? But it's true. We do talk about that, whether it's once a day, how many HIV tests they got to do, about the counselling and about going into a study, right? And they like going into a study. It was quite interesting. So we also have to break down these barriers. In Europe, okay, we've got the European CDC. They made a comment on PrEP. WHO is the World Health Organization, so although we're not quite in Europe from the UK anymore, the WHO is the world, including Europe, and EAC says, yes, PrEP is recommended. There's all sorts of pathways that you can convince politicians, community, the patients that we're on board for PrEP. But what's happening? Well, some people go, is there a real need? Yes, there is. HIV is not going away. Inconsistent efficacy across trials. Well, I've shown you that actually if you take it and support people in taking it, it works. Questions regarding safety. There's very few safety problems with PrEP at the moment. Selection of resistance. I've shown you the data there. Impact on sexual behavior. But it's really the issues of cost. And people don't want to pay. But with generic Truvada, and that's what Europe has to get hold of. It will become generic soon, and I think in a year's time, when it's all generic, a lot of governments will then start to consider it more seriously, and of course those implementation challenges. So here's a way round getting through not having to pay $4,000 or $5,000 a year for PrEP. So in our clinic, and this was presented at one of our meetings in Oxford, we got an increasing number of MSM coming saying, how about PrEP? And so they say, I go online, I access PrEP online, I pay for it online, comes to my house, but I don't know if it's good, if the medicine's any good. Is it working? Okay? So what we do, we give them advice how to access good generic PrEP, Cipla PrEP mainly. We give them risk reduction, and we do all the usual things we do with gay men, and we offer them drug level monitoring. And Marta's been at the forefront of this here. And they come in and they have HIV and STI screening. So we are not treating them with PrEP. They are getting the PrEP themselves. We are looking after them, though, like you would look after any person. Okay, and we check them out and make sure they're all right. So in this time frame, 161 people have accessed PrEP, all MSM, mainly white males and 40 years old. Okay, so, and you can see about, we have to check the Hep B immunity, and most of them are all absolutely fine. And I'll just show you that actually, if you look at these drug levels, right, from 0 to, these are population PK, you can see that all the drug levels are satisfactory. And it's very interesting that the generic drug is a good drug. They're paying a much, much lower cost than they would if they tried to buy it privately in the UK and got branded PrEP. So this is the way we're getting around it. And hepatitis C is the same. You probably all know that people are also buying generic hepatitis C drugs. So it's very interesting how for some of these things that the government aren't supporting, that actually we could support ourselves. So what about barriers? Well, I just want to finish with this quote, that nothing will ever be attempted if all possible objections must first be overcome. So let's start now. Thank you very much indeed.